Hey all, welcome back to the Real Life Pharmacology Podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. As always, go check out the top 200 drugs. Great little study guide. It's a 31-page PDF. Simply an email is all you need to get access to that. So you can go do that at reallifepharmacology.com. All right, so I am getting into part 2 of medication errors, and I've got some scary examples to share with you in this part as well. Not that some scary examples can't happen with some of the first ones I talked about in part 1, because that certainly can be the case. But I've got some good examples here that I've pulled from my practice over the years and seeing things and talking to different patients and nurses and those type of things. So first one I'll cover is transcription error. So essentially, this is the incorrect transfer of medication information. Usually it's, patient going from, let's say, the hospital, going to a long-term care facility, or, going to an assisted living, where we have two agencies basically connecting with each other and trying to transfer that information. Classic example here is being off by a decimal point. So this can be very, very scary. So let's say the order's for 0.5 milligrams and that gets transcribed, typed into the computer, or the alternative EMR that gets typed in as 5 milligrams. Well, that's a 10x dosing error. Okay, for something like warfarin, if that's given for numerous days, that is, a potentially life-threatening, scary error. Another couple classic examples are opioids. So if you give 5 milligrams of morphine versus 50 milligrams of morphine, very, very scary error. Insulin, another example there as well. I've seen patients on 5 units of insulin. I've seen patients on 50 units of insulin. So we really, really got to pay attention to some of those higher risk agents and recognize that transcription errors, rewriting down that information, getting that information down, needs to be done accurately. We need to double and triple check and obviously verify and make sure that information is correct. And if we have questions or concerns, we need to make sure that they're verified and clarified with the prescriber, as well as potentially the pharmacy that's dispensing or sending the medications to, if it's to another healthcare setting or institutionalized setting. All right, next medication error I want to talk about is the wrong patient. Another very, very scary error. And in my world of long-term care, assisted living, where I work mostly now at this point, this can be a life-threatening error. So an example I came across was a high-dose antipsychotic. Younger patients with schizophrenia may be in that type of setting, and they may need high-dose antipsychotics to keep the symptoms of their schizophrenia under control. And in that situation, if we're, pre-dishing medications, or we're not, using identifiers, and we make a mistake with giving that, let's say, high-dose antipsychotic to, an 85-year-old, small, tiny female with cardiovascular concerns, that is potentially a life-threatening mistake. So that wrong patient one can be very, very scary. And in addition to, thinking about one medication, many times these patients get multiple medications at the same time. So now all of a sudden that error might be, that error might be enhanced times 5. Maybe you're giving them 5 pills, and all those medications together, combined with their conditions and different setting, could lead to certainly a catastrophic outcome. And I have seen that catastrophic outcome happen, unfortunately, throughout my career. So pay attention to that wrong patient error is a huge one. If you're somebody who's administering medications within an institutionalized setting where you've got multiple patients around and mistakes that could be made there. This next medication error is on probably more so the little bit more the pharmacy side, preparation or a compounding error. So that's incorrect formulation or mixing of a medication, diluting a medication with the wrong solution, which may cause precipitation or incompatibilities. This is a situation where hopefully this medication error is, or this type of error is caught before it gets to the patient, because maybe the solution will look wacky or inappropriate or that type of thing. So preparation, compounding error certainly can happen, and it may or may not be visible with those type of errors depending upon the specifics. Administration technique error. I would say this is mostly on the patient side, but certainly medication aides and nurses can potentially do this as well as improper education too from a pharmacist or a provider. Again, administration technique errors, improper method of giving the drug. From the patient side of things, I've seen and heard of inhaler techniques that are just atrocious, where basically the patient is almost using it as like a hairspray type of thing with an inhaler, where they're just puffing it a couple of times around their face and not getting, obviously inhaling enough of the full dose there. Another situation that I've seen, heard of, is patient who didn't take off the needle cap for the administration of insulin. So just things like that, where a brand new patient using some of these devices and medication administration techniques, they're not familiar with it, they're not comfortable with it, and a lot of times many of them are embarrassed to ask questions and things. So really, as a healthcare professional working with patients, encourage them to ask questions, encourage them to become comfortable through asking those questions with how to do it. Okay, so really, really important there on the patient education side, making sure patients are comfortable with any type of devices or techniques in using them. Then we've got allergy-related errors. So I've actually seen this quite a bit, where we give a medication despite an allergy listed on their allergy list. I would say most often the patient doesn't have a true allergy and it's fine. Probably the classic example I've seen is baby aspirin. I've seen that probably a dozen times, maybe even close to a few dozen times, where patient has an aspirin allergy, or it's listed in their allergy list, and they're taking baby aspirin. Okay, so now it's likely the case where it's like baby aspirin is tolerable, but maybe they didn't tolerate higher dose analgesic, antipyretic dosages, but you guys should be clear in documentation what the issue is. So if it's specific towards higher dosages, that the patient had GI bleed on aspirin at pain type dosages, analgesic dosages, we'll document that in the record so we know. Okay, so that's just an important thing, because I've seen numerous patients with an actual allergy to a medication, and they're receiving it on a routine basis without issues. So again, clean up that allergy list, remove it if it was a mistake, or put some context to that allergy in the allergy section if possible. Contraindication or drug interaction error. So essentially, prescribing, dispensing a medication where it should be avoided, whether that be a contraindication for a condition or a potential, contraindicated drug interaction. So classic example here would be giving a nitrate type medication such as Imdur to a patient who's also taking a PDE5 inhibitor like sildenafil for erectile dysfunction. Medication reconciliation error. So this can kind of be lumped in maybe a little bit with transcription errors, at least in that transfer from different healthcare settings, so hospital to long-term care, for example. So doing that medication reconciliation, I'll kind of divide it into a little bit of subcategories here, but we can certainly have an omission where something they should be on actually, didn't make it or didn't get transcribed, or we can have something, erroneously stopped and or potentially incorrectly restarted. And so one classic example that I came across many years ago was actually lamotrigine, medication used potentially for bipolar depression. It's an anti-seizure medication as well. But anyway, in this situation, lamotrigine 250 milligrams twice daily actually got restarted for seizure prevention. They had been off it for years and years and years. They went from a long-term care facility to the hospital. The hospital had old records, and that lamotrigine got restarted at 250 milligrams, and they got sent back to the nursing home. And me working as a consultant pharmacist was fortunate to end up catching this one. So that lamotrigine actually has a really special titration with that medication. You want to titrate it really slowly, and if you want more details, go listen to that podcast in the past that I've covered that drug. But the risk is a life-threatening rash if you're too aggressive with the dose, and that was exactly the case. They did start to develop the rash, but we got the medication discontinued quickly enough, and it didn't progress too much further to a very severe situation. So that medication reconciliation, so important. I see so many mistakes, so many errors, and when you've got patients coming to the hospital, make sure you get that med list right from the start. Make sure you update hospital records accordingly, and then when they get sent out of facility, make sure that we're comparing what they came in on, what was added, what was changed in the hospital, and getting that right and sending them home as safely and accurately as we possibly can. All right, next error I want to talk about, calculation error. So that's a math mistake in dose calculation. This can be pretty scary in opioids and dealing with liquids and concentrations. So, if you're not great with math, not great with numbers, not great with concentrations, have somebody double check your work. Okay, really important. And if something feels off, if you need to use multiple syringes for a dose, if you, are doing unusually high volumes, for example, that should raise some flags in your head to ask and double check. Like, okay, this seems like a lot. Like maybe I'm doing something wrong here. Go ask, go double check if you have any type of inkling that you're, not thinking correctly. Another calculation error that comes up is pediatric dosing. When we're talking pediatrics, we're talking, kids, babies that weigh 5 to 8 pounds, and we're talking 12-year-olds that might be 150 pounds. Okay, so that variation in dosages in pediatrics is massive for sure. So pay attention to that pediatric dosing, recognizing ages and weights and those type of things. One last mistake I want to mention is with weight-based dosing, making sure that you're converting appropriately. If it's milligrams per kilograms and you get the weight in pounds, you got to make sure to do that conversion to kilograms and make sure you're doing that accurately. So lots of negative consequences can happen because of poor calculations. Expired medication error, something I see maybe periodically. Usually it's with like standing order medications and house medications and long-term care assisted living, where we actually give a medication that's expired. Last one I will mention as we're wrapping up medication errors is look-alike, sound-alike errors. This would maybe be coupled with wrong drug errors, which I talked about, I believe, on the first part. So look-alike, sound-alike errors or look-alike, sound-alike medications. So confusing between similar drug names, and obviously giving the wrong drug or the wrong medication. So always good to go look at that list. There's a look-alike, sound-alike list online. ISMP, Institute of Safe Medicine Practices, I believe, has one. Example, confusing clonidine with clonazepam. That's an example of, two drugs that kind of look similarly. Oftentimes, these medications also have dosage ranges that are close to each other. And so then it might be a little bit easier to get them mixed up as well. So really, really important to understand that look-alike, sound-alike list and pay attention to that. All right, well, that's going to wrap up the podcast for today. Do me a huge favor, support meded101.com/store. I've got tons of resources for pharmacists taking the BCPS exam, ambulatory care, geriatrics, NAPLEX. I've got a nursing pharmacology review course. We've got tons of Amazon books with case studies, clinical pearls, pharmacology help, all sorts of different resources, whether you're a pharmacy technician, nurse, pharmacy student, or pharmacist. So again, go check out all those resources. Can be really, really helpful, I think, in your practice and growing your knowledge base. You can do that again at meded101.com/store, STORE. In addition, if you got comments, questions, suggestions about new content that I should try to do, reach out to me, mededucation101@gmail.com. You can connect with me on LinkedIn as well, Eric Christensen, PharmD, BCPS, BCGP. I've got YouTube, Instagram, Facebook as well. Look up MedEd101. You can track me down there. I do my best to respond to all those messages, but I would say probably email is the best to make sure to get through there. Otherwise, LinkedIn is probably second best as far as messages go. If you enjoyed this podcast today, please leave me a rating and review on iTunes or whatever platform you're listening on. I greatly appreciate that, and appreciate all your support in general for sharing this podcast, with other students, healthcare professionals who could benefit from some pharmacology education. Thanks so much for listening. Take care. Hope you have a great rest of your day.